Смотри, он будет стоя рассказывать, ходить и указку переключать. Все, ладно. Ну вот, говори тогда.
Good morning, everybody. Good morning. Yes, please. That's okay. Have a seat, please. So let's start. First of all, for those who don't know me, maybe some of you familiar with me, you know me before. Dr. Iyad Imad, Associate Professor of Urology at your university. Finally, we worked many months on this day to bring a famous doctor from Dubai, from United Arab Emirates. It is my honor today to introduce him. Dr. Yasser Farahat. He is a consultant urologist working in a very big and famous hospital in UAE, hospital under presidential affairs. The name of hospital, Sheikh Khalifa Hospital. It is very famous and big hospital in UAE. Dr. Yasser is a consultant urologist professor. He's a professor of urology at Tanta University in Egypt. He is head of a scientific section in Emirates Urology Association and General Secretary of Arab Association of Urology. So let's welcome Dr. Yasser to listen to his interesting topic, which is about robotic ureteroscopy. So robotic, it is very rare or very few people in the world who are doing robotic surgery with a flexible scope. We have only one center there in UAE, I think in the region also, the only one robotic machine with Dr. Yasser. So let's all of us see and share with him his experience. Welcome, Dr. Yasser.
Thank you. I really appreciate Dr. Imad for helping me to have this connection between the Arab Association of Urology and this wonderful facility. As Dr. Imad mentioned, I am originally from Egypt. I am professor of urology at Tanta University, and I moved and joined the work in United Arab Emirates since 2010 till today. I'd like to have this lecture to be, feel free to discuss, to interact, to ask questions. If something is not clear, let us to have it. Engagement is not a matter of that we are giving only just a lecture. And before I start, I'd like to know the majority of the countries that you are. There are some from Arab regions, some people. Yes, and we have some from India, maybe. Okay, majority, yes. Okay. And from Russia, there are some students. So English is fine. That's perfect. So actually, as Dr. Imad mentioned, the role of robotics, all of us know about the robotics in different fields of urology and other surgeries like the Da Vinci robot. But what about the robot with retrograde intrarenal surgery? Is it the way to go? Are we really need for such technology? Because you know that Da Vinci can be used for multiple specialty, multiple surgeries. So if you have a device or equipment in your department or in your hospital, so it can serve a different specialty. But robot for retrograde intrarenal surgery, that's only for a single subspecialty, which is urology. So before going to such what's called sometimes fancy technology or high tech in medicine, we have to ask ourselves, does we need a robot for flexible ureteroscopy for retrograde intrarenal surgery or not? Because if you spend money, effort, time for something should has a value or add a value. But to answer this question, we have to think about the flexible ureteroscopy. Are we feeling that flexible ureteroscopy are growing up or declining. If this technology, because treatment of renal stones or ureteric stones, it depends either by ECNL or ureteroscopy or the shock wave. So we have different alternatives. So what's the position of retrograde intrarenal surgery in treatment of stone diseases? So to understand if it is growing up, it has more indication or not, we have to understand or to revise ourselves what's the complication and the limitation of flexible ureteroscopy. If we look to the literature, what's the complication of flexible ureteroscopy? So let me to ask you, do you have any idea about what's the main complication that happen with ureteroscopy? Anyone had any information about the complication that may happen? Actually, the complication with ureteroscopy is not a common complication, is not a major complication. Most of them are minor complications that you can overcome it easily without need for further surgical intervention. You can just put a stent if you have just a small tear or just injury to the mucosa. So majority are minor, but we have to keep in mind that we have some major complication, and the nightmare of the ureteroscopy for any surgeon, if you have a avulsion of the ureter, which is really a big issue, but it's not a common. But if you are well-trained and you are dealing with the tissue in a respected way, you will avoid such a complication. And if you can see, this is a real case that a ureter has been avulsed totally outside the urethra, which it means that you have to go for a major correction for that, either by autotransplantation of the kidney or replacement of the ureter by loop of ileum, which is really a big surgery and has a longer-term complication. But we have to learn how to avoid such complication. The most important thing that we have to be delicate when we are dealing with the ureter and the stone. Look to that video. If you are pulling the stone, which you catch it with the Dormier basket, you feel sometimes that the tissue, soft tissue, is coming with you. So it means a vigorous pull or traction to the mucosa, and that can lead to a urethral avulsion, as we can see on the image on the left side. The most important thing, which is a blind basket, always when you are catching the stone with a basket, try to keep the field clear, and you can see the full wires of the basket to avoid this blind basket. It's sometimes not only during pulling the stones, but sometimes during introduction of the scope itself, which can lead to intersusception. We have to understand the anatomy. If we are familiar with the anatomy, and we should know that the ureter is not a straight tube, it moves in different directions. If we remember, from anterior to posterior and from medial to lateral in different locations. So when we are going even with the rigid scope, we have to recognize on the right video, on the lower right bottom, you can see there is a tear or there is a false passage. So we have to know when to stop and when to withdraw our scope, and we can find the normal pathway to go with the scope at the end. Again, keeping in mind, this is another example of the trauma or injury, which is the severe injury of the ureter. You can see the full thickness of the ureter has been traumatized, and even some fragments of the stone is going outside. And this shows us the importance and the safety of using the guide wire so you can stent your patient. So again, the message that we want to say, how to avoid the complication. Familiarity with the anatomy of the ureter is very important, and we have to know that it doesn't move. It's as a straight tube. It has different curves at the pelvic-ureteric junction and at the pelvic brim, and the junction between the ureter and the bladder in two directions, lateral to medial and posterior to anterior. So this is the main thing for the ureteroscopy, that the avulsion or the trauma or severity, based on the severity. Otherwise, all our minor complication is not common, not frequent. So this giving us impression that ureteroscopy is growing up, is not declining as a treatment modality of urolithiasis. If we look to the data coming from the Clinical Research Office of Endourology, this is one of the biggest endourology organization internationally and running a multiple study in multiple centers. We found the stone-free rate is 85%. None of us happy with this percent of having your patients stone-free 85%. So it means that every 100 patients, you have 15 patients still having a residual stone that may need another procedure. So our objective is to improve this % of stone-free rate. So we have to revise what is the reason that there are some residual fragments in our patients, why some of them are not stone-free rate, because the irrigation is one factor. If you have an irrigation, it can push the stone. Or if you have an old technology of lithotripsy modality like electrohydraulic, if you don't have the laser and you don't have the flexible ureteroscopy. So this is the main two factors that can lead to migration of the stone, and even it can lead to residual fragments. So this is one time, sometimes to avoid, you have to catch the stone with the dormia, and then you can use the laser to reduce the size, and then you can pull it out safely without injuring the ureter, without keeping the fragments of the stones to be migrated up, and patient is not a stone-free. So overall, the post-operative complication, as we mentioned, it's minor, it's few, and all of them could be corrected. And this is how the irrigation that we have, either different modality, but each one should select the best modality that he can utilize. The ideal is to use the gravity-driven irrigation. Why? Because if you are using high pressure, the high pressure, it will lead increasing intrarenal pressure, can induce multiple problems later on. Using the urethral access sheath, I think some of you may be familiar that you are putting access sheaths and the scope can go inside. So you are giving a chance for backflow of irrigation to come through the access sheath. And the access sheath also protect the walls of the ureter when you go multiple times inside the scope, inside the ureter. So reducing the injury, reducing the complication, reducing the intrarenal pressure. And again, the new technology of how to prevent the stone to migrate, like different devices like the stone cone or any trap. There are multiple in the market to catch the stone to prevent its migration against pressure of the fragmenting device. Also, the new technology of the laser, I will go quickly. You can see some lasers can even push the stone far away, but with the new technology of the laser, if you can see in the difference between on the left side, upper and lower image, how the stone cannot be moved with the laser. So you have different modalities, different parameters of the laser to control the fragmentation or dusting of the stones. And if you have this newer laser, so you have multiple modality, you have energy plus frequency plus pulse duration, combination between different parameters. It gives you more flexibility how to handle the stone, better fragmentation or better dusting, and without significant residual fragments. And at the same time, it will make your procedure easier and faster. So after I went away from the robot to share with you how the complication or what's the limitation that led us to help us to answer the question, do we need a robot for this modality of treatment or no? I think till now we have the complication are minor, are few, and success rate can be improved more than 85%. So we are expecting that flexible ureteroscopy is growing up and sharing a significant part of treatment of urolithiasis. But what other limitation? We have some factors that sometimes we say, no, this is not the best modality to treat the stone based on the anatomical factor. We have a stricture of the ureter, so we cannot go inside easily. And if you have a stone factor, the large stone, for example, which is not suitable to be finished in one stage, or that the instruments in my hand is not suitable with the ureter, which I have. But I think if we are familiar with all these points, we will select the best patient to the best tool in my hand. So if I have just a stricture, I can put a stent for the patient doing the dilatation and keep a second stage for flexible ureteroscopy. Stone size, we should follow the guidelines based on the proper size that can be finished in one session, and which is usually 1.5 and up to 2 centimeters, we can go for flexible ureteroscopy. We'll come back to the most challenging, which we faced when I started in your age 30 years ago. When we started, the size of the scope was 11 to 13 French, which is really big. But if you look during the last 20 years, how the development of the instruments, growing very fast and in the favor of flexible ureteroscopy regarding to moving from rigid to flexible, because earlier we have only the rigid metal one, but now we have the flexible. Refinement and improvement in the size. Instead of 11, 13 French, now we have 7.5, and sometimes we have 5.31. And improvement in the working channel, because if you can introduce a laser fiber, or if you introduce a Dormia basket, so refinement in the working channel help it also to improve and develop this tool in your hand. Refinement in the irrigation, as we mentioned, irrigation is important for better visibility, to control the intrarenal pressure. So if you have a good channel, good irrigation, this gives you impression with the improvement. The most challenging part, which how to reach to the different calyces, but the new scopes giving you a very wide range of deflection that you can navigate the whole renal calyceal system easily, upper, lower, or middle, anterior or posterior group, so in different direction with a good deflection. And the huge improvement that happened in the last 10-15 years about the shift from the fibro optic scope into the optical one, which gives you a definite change in the clarity of vision and in depth perception, infiltration, in color. So the technology nowadays is improving the visibility, and you can find the minor details of the vessels, of even if you have a tumors, or if you have small stones. So the clarity or refinement in the image quality is very important. So it's not only the scope itself, but the accessories that we needed for the scope, like the laser fiber in different sizes with different types of laser, the other accessories like forceps, Dormia, and these anterior trubulgent devices, which prevents to migration, the access sheath that can help you for entry for multiple times to the ureter. So a lot of improvement in the scope itself, in the accessories. So size of the stone we can control, type of the stone we can select, and the anatomical problems, if we have a structure, we can dilate or make it a staged operation. So let me to ask all of you regarding to the complication or limitation, any one of you agree with me or disagree that flexible ureteroscopy is growing up or not? It looks growing up, so it's a good modality, and it will take place within the paradigm of treatment of urolithiasis between the BCNL and between the shockwave. And this has been reflected even in the guidelines. If you look to the European guidelines, in case of PNL or PCNL is not an option, large stone more than even up to more than 2 centimeters can be treated by flexible ureteroscopy. Even for lower pool, because you know the lower pool is a challenge because it sometimes has unfavorable anatomy that it can make it difficult. So still up to 1.5 centimeter stone can be used by flexible ureteroscopy. We look to some centers with a high volume of flexible ureteroscopy from our colleagues from Paris, Dr. Trexer and Dr. Saeed Ben Hamri from Saudi, up to 2.6 centimeter stones, and they got stone-free rate up to 95%. Yes, it's not from a single session. Sometimes it's due to in 2 sessions. So even this data giving us confident that flexible ureteroscopy is growing up. But this does that mean that we can say goodbye for other modality, stop shockwave, stop PCNL? If we have something growing up, it's not replacement to the others. We have to keep in mind, if something is growing, it doesn't, others are dying. No, there is indication for each modality, and based on what you are expert or what you are doing it in a proper way, so you can still have a place for PCNL and shockwave. If we look also to the still some hidden limitation, which is the cost. And we have to consider that when we are treating a patient, if flexible scope is an expensive tool in comparison to other modality, so we are adding extra cost to our patient, and the scope is fragile, and the longevity or the ability of the scope to live long is not that much, and it induces some ergonomic problem to the physicians or to the surgeons because you have to use it manually, so sometimes it induces some ergonomic problem. So here we will come to the answer of our question. Are we need a robot to help in such a modality? So if yes, if it can improve the efficacy and get better stone free rate, going for a larger stone. If it reduces the adverse events like trauma or injury, or it can reduce the professional hazard. Sometimes we forget ourselves as a surgeon. If you are working close to the radiation, if you are doing some vigorous movement for multiple patients all the day, so you can get some orthopedic problems, and to reduce the damage of the scope itself, because as we mentioned, it's fiber optic sometimes, or even digital, it's still fragile and can be damaged easily. So if this robot will help us to do all of this and save that, so yes, we can do. But I will come back when I think you are here in the hospital, you attended Da Vinci or robotic surgery. The room setup little bit is relatively takes time to be adapted to have the room setup, and the maintenance of the scope of the robot is really sometimes difficult. But for robot assisted flexible ureteroscopy, it's very easy. Once you put the manual insertion of ureteral access sheath, just connect the scope to the arm of the robot, and then connect to the irrigation, connect to the laser, and you are here ready to go. And you can control everything while you are sitting, just in 3-4 steps. It doesn't take more than 10 minutes. And then you will be able to control all functions that you need from a console while you are sitting. You can rotate, you can move the scope, you can fragment, you can use the laser, and you can control everything from a screen that we will go quickly into details about this screen and how you can control everything. So you sometimes you feel that you need to have a cup of coffee while you are doing the surgery, because once everything, the setup is already in place, so you can fragment the stone, you have all facilities in one screen. So how this is the screen, the simple screen of the robot is divided into 6 icons. The number 1, which you can control the vertical and horizontal movement of the scope. So if you need to raise it up, down, or move it inside the patient or outside the patient, you just click a button so you can have this movement. And the second screen, you can control the irrigation, either manually increase it 1 by 1, or if you have unclarity and you need some flush to improve the visibility, so you can have it. Laser control is very important because you have here a safety measure. There is a chip at the tip of this robot that can identify if the laser is very close to the tip, so it will not fire even if you press accidentally the pedal of the laser. So it protects the fire back of the laser effect on the scope. So this is a very important one. Look to the accuracy of the deflection. If you are moving manually the scope, you cannot move your hand 360 degrees. You have to go and help with the other hand. But with the robot, you can move more than 44 degrees in one rotation, because you will move, it will rotate. It's different than the manual. Sorry that the image is upside down. And here also the other accuracy about the deflection. When you move with your thumb, the deflector, the tip of the scope, it moves 10 degrees, deflects at 60 degrees. So it's not matching together, but with the robot, they make it adjusted, because 10 degrees, it equals 13 at the tip. So what you are doing with the thumb outside the patient is almost the same as the tip, how it moves inside the kidney or inside the patient. This gives you more precise accuracy of the controlling the scope. And here the pedals, you can control the laser in one foot, and you control the fluoroscopy or radiology from other foot. So you are controlling everything while you are sitting in a console. And this is the 5 years data that we have. We are strict to the average size of the stone 1.6, and the average timing is combined, both docking and the fragmentation is 45 minutes, and stone free rate after 3 weeks is we reach it to a good percentage, is a 93%. I'll just remind you quickly about the professional hazard that we mentioned. Sometimes you have wrist problems. You are sitting close to the radiation if you are between the patient legs in the lithotomy position, but now you are sitting in a corner away from the patient, so the exposure to radiation is less for yourself and for your staff, and you are avoiding the ergonomics problem. What about the training of how you can learn? I can assure any of you, if you just come to do this training on a kidney model in 3 to 5 times, you can be familiar to how to handle this robot. It's very easy. If you are familiar with the PlayStation, you will be better than us. Because I can tell you, this is the older version of the robot. The newer one coming from the States and other one from France, it's actually they modified it into like joystick. So anyone professional in PlayStation, he will be a robotic surgeon. It's very easy. And this is what's scaring me. You'll be better than me. So I believe we reached to answer still limitation. Anyone feel there is a limitation to use the robot with the flexible scope? I say still yes, we have to be more practical. I will not be pushed to what I like or what I am using. Still, I have to consider practically with the negative side that the still is scope damage, because as we said, the scope is fragile. But the market came to us with the what's called a single use flexible ureteroscopy, and it's matching or adaptable also with the robot. So even for learning or for institutes like the university where we want people to learn and without risk of damaging an expensive tool, so this single use one, it can be helpful and it can be used and improving the learning curve easily without adding a cost to the hospital or organization or the university or institute. It's very easy, and you can see you have a brand new in your hand and you can try it as a new with every patient, and the clarity of the vision, and you can use it similar as the reusable one and using the laser, using the Dormia basket. So it's the same as the other one. I took long time, but before leaving, I just want to review with you the message that we want to say. Ureteroscopy has a complication. Yes, we cannot say without complication, but majority are minor and can be corrected without causing a severe damage or a severe problem to the patient. And the most important to avoid this complication is your better understanding of the anatomy of the ureter and how to handle gently the soft tissue and consider the directions of the ureter. And the new development of the scope, if you are familiar with the new technology and using the new one, it will help you to reduce this complication. Stone migration and the residual fragments is still, we are ignored to add it as a complication, but it will end up with your patient not stone free from one session, and he may need a staged operation. But new laser technology, if you have it in your department and having the single use also, it can improve the efficacy and shorten the operative time and may help treatment larger stone. Keep in mind, everyone should keep in mind the balance between risk and benefit before deciding what tool you are going to use, and not only risk benefit, also the cost, because patients are our families and our friends, and we have to consider that. Robot is an added advantage to retrograde intrarenal surgery, improving stone-free rate, reduce staged procedure, treating larger stone, improve scope longevity, and reduce the professional hazard. I hope that you enjoyed the lecture, and I'm ready to have any questions. And some people still need coffee. Yes?
Thank you. Thank you, Dr. Yasser. It was really interesting topic, and in fact, there are some students here are sleeping, and some of them busy with the phones. Maybe it is more interesting for students who like to become a surgeon or a urologist. I do understand maybe for people or for students who want to be, you know, an internal medicine specialist, maybe that is not very interesting topics. But believe me, today you had an opportunity to see and to listen to things, to the unique things which can happen very rare in the world. You should be proud that you are here and you are listening to Dr. Farahat, because he gave you the things which even senior urologists, they don't know and they don't practice this. So can you imagine when you make a tour inside the kidney and you are like playing on the PlayStation and enjoying? And as he mentioned, sometimes you need to have, you feel that you need to have like a cup of coffee, you know, because it comes with experience. So please, if you have anything in your mind to ask, you can ask any question, especially from this part. I see more active here.
No, both are fine.
Any question? Yes?
Yeah.
Hmm?
Yes, feel free. Can you introduce yourself?
Ma-
Yes, welcome.
No, it was mentioned.
Okay. I will go back to the data that I mentioned. So this is the average docking time. Docking time means how my nurse or assistant will adjust the robot arm itself and prepare it in the room.